Everyone, so welcome back. Today we are going to be learning about inguinal canal. This is a very important topic, not only anatomically but also surgically. When you people go to your surgical postings, it is compulsory to know about inguinal canal, and it is also a very important question in university exams as well. So today we will be looking into inguinal canal. So here is the question. The question says us to describe the inguinal canal under the following headings. It is its location and extent, the openings, the boundaries, the contents, that is nothing but the structures passing through it, the natural safety mechanisms, that is nothing but the factors preventing inguinal hernias, and the applied anatomy, as well as add a note on inguinal hernias. So this is a 10-mark question. It is very important question, and it is very important as a clinician to know about inguinal canal as well. So what is inguinal canal? It is an oblique intramuscular passage about 4 centimeters long, lying above the medial half of the inguinal ligament. So they are telling that the inguinal canal is an oblique intramuscular passage. It is not straight like this. It is oblique. It is like this. Yeah, and its length is about 4 centimeters, like it is 4 centimeters long. And where does it lie? It lies above the medial half of the inguinal ligament. We all know that the inguinal ligament extends from the ASIS to the pubic tubercle, and the medial half, that is over here, we have the inguinal canal located. Either you can use this definition or you can also use this definition, that is, it is a canal passing through the anterior abdominal wall between the external oblique aponeurosis anteriorly and the fascia transversalis posteriorly. So it is a canal that is passing through the anterior abdominal wall. This is your abdomen. The entire and in the anterior abdominal wall, where does it pass? See, in the anterior abdominal wall, we have the external oblique muscle, and posteriorly we have the fascia transversalis. In between these two, there is a canal that is nothing but your inguinal canal. So its extent. What is it? It extends from the deep inguinal ring to the superficial inguinal ring. Okay, so we will look into it later, where the deep inguinal ring is present, where the superficial inguinal ring is present. For now, just remember that it extends from the deep inguinal ring to the superficial inguinal ring. Its length is 4 centimeter. Yes, we already discussed this. It is obliquely directed. It is obliquely directed, and it is directed downwards, forwards, and medially. So if this is the person and this is his abdomen, it is directed like this. It is directed downwards, forwards, and medially. Like he is the person, like this you can say. It is going downwards, it is going forwards, and it is also going medially. This is the so it's going medially. So it is like this. Okay, downwards, forwards, and medially. So this is the diagram. See, this is the ASIS, that is your anterior superior iliac spine. This is the pubic crest. This is the linea alba. This is the deep inguinal ring. This is the superficial inguinal ring, and the canal extends between these two. As you can see, it is directed downwards, forwards, and medially. So next, superficial inguinal ring. See, ring means we all think that it is a circle, right? But superficial inguinal ring is not like that. Superficial inguinal ring, it is triangular in shape. It is a triangular gap present where? It is present in the external oblique aponeurosis, and it is marked just above the pubic tubercle, where if we ask you to locate superficial inguinal ring, you will tell that it is just above the pubic tubercle, and it is a triangular gap in the external oblique aponeurosis. See, the center of the superficial inguinal ring lies 1 centimeter above and lateral to the pubic tubercle. If somebody asks you to locate the superficial inguinal ring, you will locate it. It lies 1 centimeter above and lateral. It lies if this is the pubic tubercle, it lies 1 centimeter above and lateral. That like this over here somewhere. Lies 1 centimeter above and lateral to the pubic tubercle. So this, you can see, this is the superficial inguinal ring. This is the lateral crura. This is the medial crura, and these two are joined by intercrural fibers. And below this is the pubic crest. It forms the base of the triangle. Next, moving on to the deep inguinal ring. Deep inguinal ring, yeah, this is not triangular now. It is like a ring only. It is an oval opening where, see, deep inguinal ring is present posteriorly. So it is like it is an opening in the fascia transversalis. And if we ask you to locate where is the deep inguinal ring present, if somebody asks you to locate it on a person, where will you locate it? It is marked 1.2 centimeters or half inch above the mid inguinal point. So now what is mid inguinal point? So this is a very important question. Where will you first mark it? You will mark it half inch above the mid inguinal point. But what is mid inguinal point? Mid inguinal point, it is the midpoint joining the ASIS to the pubic symphysis. Okay, mid inguinal point is different from midpoint of inguinal ligament. These two are it is very important to know the difference between these two. Let us understand the easier one first. Midpoint of inguinal ligament. The answer is there in the sentence itself. It is nothing but the midpoint of the inguinal ligament. We all know that inguinal ligament extends from the ASIS to the pubic tubercle. So midpoint of that is nothing but midpoint of inguinal ligament. So now what is mid inguinal point? Mid inguinal point, you just have to change it from the pubic tubercle. Instead of pubic tubercle, here it is pubic symphysis. So it is nothing but it is the midpoint joining the ASIS to the pubic symphysis. This is known as mid-inguinal point. And where is our deep inguinal ring situated? It is marked half inch above the mid-inguinal point. Okay, this point, that is this marked half inch above the mid-inguinal point. So now moving on to the boundaries of the inguinal canal. As you can all see, this diagram is very important, and if you understand this diagram, you can write the boundaries, the relations, everything on your own. So anteriorly, the entire extent of the abdomen, we all know it is covered by external oblique aponeurosis. Okay, and over here we have this gap, so that is nothing but your superficial inguinal ring. Posteriorly, this is your fascia transversalis, and over there we have this gap, that is nothing but your deep inguinal ring. So what are the boundaries of the inguinal canal now? So see, here you have the internal oblique muscle, and behind that you have the transverse abdominis muscle. Okay, so this is nothing but your transverse section of your inguinal canal. So first we will look at the anterior wall. Anterior wall, obviously, if we come from the outer side, it will be skin, superficial fascia, and the external oblique aponeurosis in the whole extent. These three are present in the whole extent of the abdomen. You have the skin, superficial fascia, and your external oblique aponeurosis in the whole extent. Now if you look furthermore behind, internal oblique muscle, you can see that it is not present in the entire extent. It is not present this side. So we will tell that it is only present it is only present in the lateral 1/3. Okay, internal oblique muscle is present only in the lateral 1/3. So you have to take only this. So this dotted line, we are going to see only in this box. Okay, this dotted line. So it is present only in the lateral 1/3 part. Internal oblique muscle is present. So posterior wall, if we see from deep to superficial, it is covered by fascia transversalis in the whole extent. Then you have the conjoint tendon in the medial 2/3, and you have the reflected part of the inguinal ligament in the medial most part. So if we look into this diagram, posteriorly in the whole extent you have the fascia transversalis. Then you can see that this internal oblique muscle and your transverse abdominis muscle, they both will arc like this, that is, they will form the roof. Okay, so these are nothing but the arcing fibers of the transverse abdominis and internal oblique muscle. They both will form the roof like this, and they both will go upwards, and together they join and they form this common tendon that is known as conjoint tendon. So this is a very important thing to remember. This side, these two are present as separate muscles, and while going on the roof, the arcing fibers are present which join together and they form this common tendon, that is conjoint tendon, which is present posteriorly. And then you have the reflected part of the inguinal canal, which is present in the medial most part. So if we have to revise, anterior wall, we have skin, superficial fascia, external oblique aponeurosis in the whole extent, but you have the internal oblique muscle only in the lateral 1/3 part. In the posterior wall, deep to superficial, first we have the fascia transversalis in the whole extent, then you have the conjoint tendon in the medial 2/3 part, and then you have the reflected part of the inguinal ligament in the medial most part. Okay, Look, in the medial two-third part we have the conjoint tendon. The medial most part we have the reflected part of inguinal ligament. So one thing you have to note is that transverse abdominis muscle does not contribute in your inguinal canal. Like it does not contribute in the boundaries of the inguinal canal. See, transverse abdominis muscle, it does not. So we are looking only inside this dotted line, and it is not related to your inguinal canal. Other than that, every other muscle is related. So this is another section. If you take, you will be able to appreciate the floor and the roof of the inguinal canal. So this is your inguinal canal. This is the external oblique aponeurosis, and we all know the external oblique aponeurosis only will go ahead, and when it bends, it forms your inguinal ligament. So it is nothing but like the modification, you can tell, or the external oblique aponeurosis only, it extends and curves to form your inguinal ligament. So this below you can see inguinal ligament plus the lacunar ligament. We will look later into what a lacunar ligament is. So this is a sagittal section in which we can clearly see the transverse abdominis and the internal oblique muscle and their arced fibers which will join to form the conjoint tendon posteriorly, and these two, the arced fibers of internal oblique and transverse abdominis muscle, they will form the roof of the inguinal canal. So the roof of the inguinal canal, it is formed by the arced fibers of the internal oblique and the transverse abdominis, and the floor is formed by your inguinal ligament and lacunar ligament. So what is lacunar ligament? We will look into it now. So we are gonna be studying about the modifications of inguinal ligament. So first of all, what is inguinal ligament? It is an extension or the modification of aponeurosis of external oblique. See, I told you, right? This external oblique muscle, this external oblique aponeurosis modification is only nothing but inguinal ligament. When it rolls downwards and curves inwards, it is nothing but your inguinal ligament. Now we are looking into the modifications of inguinal ligament. First we will look into the diagram. This is nothing but your linea alba. This is the pubic tubercle. The line joining the ASIS and the pubic tubercle, we all know that this is nothing but your inguinal ligament, and this is the pectineal ligament which runs in the, we will see that it runs on the pectineal line. Okay, so that is nothing but pectineal ligament. This is the reflected part of the inguinal ligament. Yes, can you all tell me what boundary does it form? It forms the in the posterior boundary, it forms the medial most part of the inguinal canal. That is nothing but reflected part of inguinal ligament, and between these two you can see that this part is nothing but, this is only your lacunar ligament. So now we will go into the theory part. Modifications. First one is the pectineal ligament. It runs on the pectineal line, that is on the pecten pubis. The second one is your lacunar ligament. It is a triangular fold stretching between the pectineal line and the inguinal ligament. As you can see here, it is a triangular fold stretching between your pectineal ligament and the inguinal ligament. It contributes to the floor of the inguinal canal. Yes, we already saw it in this diagram, that is in the sagittal section. Okay, so moving on, next is the reflected part of inguinal ligament. It runs downwards, it runs towards the midline and attaches to the linea alba. See, it runs towards the midline and it attaches to the linea alba. It forms the posterior relation of the inguinal canal. We already saw it in the relations of the inguinal canal. So these are some key points to remember if any of you have any confusion between aponeurosis, to know the difference between aponeurosis, fascia, tendons, ligaments. So I'm just telling you guys this over here. So what is aponeurosis? Aponeurosis is nothing but a thin sheet of connective tissue that helps connect muscles to bones. Okay, so it actually helps to connect the muscles to the bones or muscles to muscles also. It does both, and these are nothing but thin sheet of connective tissues. They are flat, they are broad sheets of tissues that connect muscle to other muscles or to bones, and they're usually thin. So this is nothing but aponeurosis. Then what do you mean by tendon? Tendon are usually thick. They're not thin like aponeurosis. They are thick, they are cord-like, and they're strong, and they connect only muscles to bones. They do not connect muscles to other muscles. Between a muscle and a bone, if we have to see, tendon helps in connection of the muscle to the bone, and they're usually thick, cord-like, and strong. Aponeurosis are flat, broad, and they're usually thin, and they connect both muscles to other muscles or to bones. Then what do you mean by fascia? Fascia, this also refers to a sheet or band of connective tissue primarily made up of collagen. It is primarily made up of collagen, and the main thing what it does is it surrounds and separates muscles, organs, and other structures within the body. Muscles are separated from other muscles, or muscles are separated from organ with the help of this covering called fascia, and it is usually made up of collagen. Then what do you mean by ligament? Some people might have confusion between fascia and aponeurosis, but I hope now that it is clear. Then what do you mean by ligament? Ligament are also strong fibrous connective tissue that connect bones to bones. One bone to the other bone, they are connected with the help of ligament. Okay, they connect only bones to bone. They help stabilize joints and limit excessive movement. So this was some additional information to clear some of the doubts and confusions. Moving on, we have the contents of inguinal canal. So contents are very easy. So in both males and females, we have the ilioinguinal nerve passing through the inguinal canal, and in males we have the spermatic cord passing through the inguinal canal, and in females, obviously we will not have spermatic cord. Instead of that, we have the round ligament of uterus. So one note that you need to note down is that the round ligament of uterus or your spermatic cord, they run they run in the full length of your inguinal canal. But ilioinguinal nerve, it does not run fully into your inguinal canal. It enters the canal from the side through a slit between external oblique muscle and the internal oblique muscle. So it's not a true content, but obviously it is. I'm telling it's not a true content because it is entering in between. It lies in front of the cord and passes out of the canal through the superficial inguinal ring to supply the inguinal region. So it enters midway and it passes out of your superficial inguinal canal to supply the inguinal region. So the contents are, the first content, the common content is ilioinguinal nerve. In males we have the spermatic cord, and in females we have the round ligament of uterus. So now let us look into what is spermatic cord. This itself can be a 5-mark question in itself. So this is also very important. We will look into what are the coverings of the spermatic cord, and then we will look into what are the contents of the spermatic cord. So contents of spermatic cord also comes under your content of inguinal ligament. Okay. So first, what is spermatic cord? It is a collection of structures that passes through the inguinal canal to the testis. So it is not ending just at the inguinal canal. It is going further into your testis. Spermatic cord, it is a collection of structures that passes through the inguinal canal to the testis. It extends from the deep inguinal ring to the posterior border of the testis and is covered by 3 facial layers. So yeah, it extends from deep inguinal ring, and it does not end at superficial inguinal ring. It goes till the posterior border of testis, and it is covered by 3 facial layers. So these are nothing but the coverings of spermatic cord. So we will look into what are these 3 facial layers we are talking about. The first is the external spermatic fascia, the next is the cremasteric fascia, and the third one is your internal spermatic fascia. External spermatic fascia, it is derived from the aponeurosis of external oblique muscle. Very easy to remember. External, derived from external. So the next, we all know, after external oblique muscle, we have internal oblique muscle. So cremasteric fascia is derived from internal oblique muscle, and the internal spermatic fascia is derived from your fascia transversalis. Yes, that easy. So cremasteric, we all have learnt in 12th that there are 2 muscles of the testis. One is cremaster muscle and the other one is dartos muscle. So that is only your cremasteric fascia, or you can remember it like that. First one is external spermatic fascia. Obviously, if external is there, then the other one will be internal spermatic fascia, and the other one is your cremasteric fascia. So this is the diagram of your it is a diagram which shows both the coverings as well as the contents of the spermatic cord. So in this, first we will look into the coverings. See, this is nothing but this entire green thing is your external spermatic fascia. Inside that we have the cremasteric fascia. Then we have the internal spermatic fascia. So it is, I would recommend you guys to remember the contents of the spermatic cord, and then you can just draw the diagram on your own if you remember the contents. So obviously we all know that this spermatic cord is going to the testis. Testis. And in testis, we all know what do we have? In testes, we have the vas deferens, or it is also known as ductus deferens. So the first content of spermatic cord is nothing but ductus deferens in the posterior part. Then you need to remember there are 3 arteries. Okay, this is very easy to remember. You already know that there is ductus deferens, so this ductus deferens needs an artery. So the first is the artery to the ductus deferens. Then we already read in the coverings that we have something known as cremasteric fascia. So there is nothing. So we have we have cremasteric muscle also. For that you have an artery, that is cremasteric artery. Then obviously we are talking about the testis. You have the testicular artery. So these are the 3 arteries. First, the first content of spermatic cord is obviously in testes. We all know the basic structure, that is vas deferens. So that is nothing but ductus deferens. That is the ductus deferens. Arteries. In arteries, we have the artery to ductus deferens. The second one is cremasteric artery, and the next one is your testicular artery. Veins. We don't have particular veins. We have a plexus of veins, and they are known as pampniform plexus of veins. So this is also very important. Then we already covered arteries, veins. So now next what? Next is the lymphatics. Then we have the lymphatics from the testes, and you have one nerve which is very important to be remembered. That is, it is the genital branch of genitofemoral nerve. Genitofemoral nerve has 2 branches, the femoral branch and the genital branch. This genital branch enters into your spermatic cord, that is genital branch of genitofemoral nerve. And then you sometimes you will have the remains of processus vaginalis. Okay, processus vaginalis. Now let us look into the diagram and revise the contents once again. So these are the coverings. First is the external spermatic fascia. Second is the cremasteric fascia. Yes, you guys tell me, external spermatic fascia is derived from external oblique aponeurosis. Cremasteric fascia is derived from internal oblique aponeurosis, and your internal spermatic fascia is derived from fascia transversalis. So now this is your ductus deferens. Okay. So, and the veins, the pampniform plexus and the lymphatics surround the ductus deferens. Then we have the artery to ductus deferens, as you can see, and here you have the nerve, that is your genital branch of genitofemoral nerve. This part is nothing but the remains of processus vaginalis. What is this? This one artery we have finished, that is lying close to the ductus deferens. So there has to be another artery. This is nothing but your testicular artery. Surrounding that again we have pampniform plexus of veins and some sympathetic nerves. Here we have the cremasteric arteries and the nerves. Ilioinguinal nerve, see, it is lying outside your spermatic cord, not lying inside the spermatic cord. So these two together, ilioinguinal nerve and your whole spermatic cord, they form the content of your inguinal canal. These two together, if I enclose them in one more circle like this, we get the contents of inguinal canal. So the next topic we are going to be studying is the mechanisms to maintain the integrity of your inguinal canal. So inguinal canal is a site of potential weakness and may provide herniation of abdominal viscera. Okay, so the location where inguinal canal is present, it is a site of potential weakness, and because of which what can happen, it can provide herniation of abdominal viscera. But normally, if you see in a normal healthy person, this does not occur. Why? Because our body has mechanisms to prevent this herniation. Only if these mechanisms become weak or the muscle becomes weak, then we can see herniation and hernia will be formed. So what are these mechanisms? See, normally it is prevented, the herniation is prevented due to the following mechanisms. So the first mechanism is the flap wall mechanism. This mechanism refers to the oblique nature of the inguinal canal. See, we all know that inguinal canal is not straight like this. It is oblique in nature. Now, because of this obliquity, we have an advantage because of which herniation does not occur. So this canal is oblique. Okay. See, deep and the superficial rings do not lie opposite to each other. Like I told you in this diagram, deep ring and the superficial ring lie opposite to each other. But this is not happening. They do not lie opposite to each other. So when the intra-abdominal pressure increases, the anterior and the posterior walls of the canal are approximated like a flap. Now, because this inguinal canal is oblique in nature, and when intra-abdominal pressure increases, these two rings are approximated towards each other, and they act like a flap. So this is nothing but your flap wall mechanism. Flap wall, you just have to remember one thing, that the flap wall mechanism refers to the oblique nature of the inguinal canal, because of which when intra-abdominal pressure increases, these two rings are the anterior and the posterior walls are approximated towards each other like a flap. So the second mechanism we have is the shutter mechanism. In this, what happens? See, the internal oblique muscle surrounds the canal in the front, above and behind like a flexible mobile arc. Okay, so the only muscle that is present in the inguinal canal in all the in the anterior part, in the posterior part, as well as its arched fiber. So this is the only muscle that is present like this. It is your internal oblique muscle. Transverse abdominis, though it's not a part. External oblique is present in the whole length, and fascia transversalis is present in the whole length posteriorly. So internal oblique muscle is the only muscle that is present first anteriorly, then it arches like this, and then it is present posteriorly. So that is what they're saying. So now what happens is that when this muscle contracts, it is like a shutter mechanism. The roof comes down like this. Like, have you seen shops, normal street shops, when they are closing, they put the shutter down like this and they lock it here. So that is nothing but your shutter. So that is why we are calling shutter mechanism. And who is acting as a shutter in this? That is your internal oblique muscle. The internal oblique muscle surrounds the canal in the front, above and behind like a flexible mobile arc, and thus forming its anterior wall, roof and the posterior wall. So consequently, when it contracts, the roof is pulled and approximated on the floor like a shutter. Yes, as you can see in this diagram. So if this is the roof, so when the muscle contracts, it acts like a shutter and it is approximated to the roof. Like a shop closes its shutter, like this downwards, and they lock it over here. Similarly, your internal oblique muscle also, it closes off like this, because of which the contents cannot come out. Okay, and it is approximated on the floor. I hope this is understood. This is very nice way. The name is also very nice, shutter mechanism. And which muscle is acting like a shutter? It is your internal oblique muscle. So the next mechanism we have is the slit valve mechanism. In this, what you have to remember? You have to remember your external oblique muscle is the contraction of the external oblique muscle. We all know in the external oblique muscle only we have this a superficial ring, right? So the contraction of the external oblique muscle approximates the two crura, medial and the lateral, of the superficial inguinal ring like a slit valve. So here we have your superficial inguinal ring in the external oblique muscle, and when this muscle contracts, these two crura are approximated to each other, and therefore they prevent the content coming out, and that is, they prevent herniation. I hope this is understood. We all know superficial inguinal ring is nothing but it is a deficient place in the external oblique muscle, and it is triangular in nature. So it is like this, and if this is your entire external oblique muscle, when this muscle contracts, these lateral and medial crura are approximated towards each other, which will kind of close it like a slit valve. So the fourth mechanism is ball valve mechanism. In this, what is happening? You have to remember the testis. Okay, ball valve mechanism, you have to remember testis. So here, what is happening in this? In this, the contraction of the cremasteric muscle pulls the testes upwards. This corrugates the cremasteric fascia around the superficial inguinal ring and plugs it. So this is one that you have to remember. Ball valve mechanism refers to the testis and how the contraction of the cremasteric muscle it brings the testis upwards, and it plugs it into your SIR. Okay, you can just remember this line. Contraction of the cremasteric muscle pulls the testis upwards, because of which this corrugates the cremasteric fascia around the superficial inguinal ring and it plugs it. So moving on to the last part of the video, and that is the last part to the answer of the question, that is the applied anatomy. In the applied anatomy, we are going to be learning about hernias, that is especially inguinal hernias. Yes, I mean, because we're talking about the inguinal canal, obviously we are going to be studying about inguinal hernias. Inguinal hernias are of two types, indirect and direct. In indirect, again we have congenital and we have acquired. So inguinal hernia, its definition It is nothing but a protrusion of the abdominal viscera, example loop of intestine, into the inguinal canal is termed as inguinal hernia. So when a protrusion of the abdominal viscera takes place in the inguinal canal, it is termed as inguinal hernia. So first we will be looking into indirect inguinal hernia. So it occurs if the hernial sac enters the inguinal canal through the deep inguinal ring lateral to the inferior epigastric artery. We will look, so we have, if this is the epigastric artery present and laterally what is happening, a herniation is happening, okay. That is, that too how it is happening through the deep inguinal ring, okay. If so, let me read it once again if you guys are confused. It occurs if the hernial sac enters the inguinal canal through the deep inguinal ring, okay, and it usually comes out lateral to the inferior epigastric artery. It is seen commonly in children and in young adults. It is seen in children and young adults. Indirect hernia are more common than direct hernias, and it is more common in males than females. So first thing, you will remember the definition. What is the definition? If the hernial sac enters the inguinal canal through what? Through the deep ring, and it comes out lateral to the inferior epigastric artery. Lateral to the inferior epigastric artery, common in children and young adults, more common in males than females, and indirect hernia are often more common than direct inguinal hernias. So the inside indirect only we are looking at. So the next thing we are going to be looking at is congenital indirect inguinal hernia. It occurs due to patent process vaginalis. So congenital, why does it occur? It occurs due to patent process vaginalis. What is process vaginalis? It is an outpouching of the peritoneum connecting the peritoneal cavity to the tunica vaginalis. I hope we all know what tunica vaginalis is, right? We have learned it in 12th standard that it is like the covering of the testis. So when this processus vaginalis helps in the attachment of your peritoneal cavity to the tunica vaginalis. So when this persists, usually it should obliterate, but if this persists, it will lead to congenital indirect inguinal hernia is what they are telling us. Next is acquired indirect inguinal hernia. Acquired means it is acquired in a lifetime. Like a person is born, he does not have patent process vaginalis, so he does not have congenital indirect inguinal hernia. What happens? He grows up, and during his growth, he has done some things because of which he has acquired this inguinal hernia. It occurs. How has he? What has he done? He has worked, like it occurs due to increase in intra-abdominal pressure as during weightlifting. See, as he has lifted too much of weight, because of which it has happened, or he's coughing a lot, because anything which will lead to increase in intra-abdominal pressure will cause this acquired indirect inguinal hernia, okay. So when intra-abdominal pressure is increased immensely, okay, and the abdominal contents are pushed through the deep inguinal ring into the inguinal canal, we can see this occurring. So next, so this was all about indirect hernia. So what do you know in indirect hernia? That the abdominal contents come out through the inguinal canal through entering through the deep inguinal ring, okay. So next is the direct inguinal hernia. This occurs if the hernial sac enters the inguinal canal directly by pushing the posterior wall of the inguinal canal forward, medial to the inferior epigastric artery through the Hasselback's triangle. So we already saw that this indirect inguinal hernia was occurring lateral to the inferior epigastric artery. Here they are telling that it is medial to the inferior epigastric artery, and here what is happening? It is the hernial sac enters the inguinal canal directly by pushing the posterior wall of the inguinal canal forwards. Directly it pushes the posterior wall of the inguinal canal forwards, okay. So this is usually seen mostly in elderly people due to weak abdominal muscles. Because they have weak abdominal muscles, directly the posterior wall is pushed forwards, and it comes out medially. So medial to your inferior epigastric artery in the Hasselback's triangle. So this is the Hasselback's triangle, this triangle that you can see, the triangle that I am highlighting. So now what are the boundaries of the Hasselback triangle? If you can see this, here we have the rectus abdominis muscle. Here this is your inferior epigastric artery, and this is your inguinal ligament, okay. So these three together, they are forming this Hasselback's triangle. Here you have the deep inguinal ring, and this is your superficial inguinal ring. And inside this triangle only we are making two parts. That is, two parts are made with the help of your medial umbilical ligament. This will be the lateral part and this will be the medial part. So this is the lateral part and medial part of Hasselbalch's triangle. What we learnt before was that if it appears lateral to the inferior epigastric artery, we can tell that it is an indirect hernia, and if it occurs medial to the inferior epigastric artery, it is direct hernia. Now, Hasselbalch's triangle is only divided into two parts with the help of medial umbilical ligament. That is, this forms your lateral part and this forms your medial part. Okay. So this is the posterior view of anterior abdominal wall. So this is the posterior view of anterior abdominal wall. That is, you are not seeing the patient from the front. You are imagining your own abdominal. You imagine yourself going inside your abdomen and looking at it. Okay, like take your abdomen out and you're looking at it. So that is nothing but, that means that it is a posterior view of anterior abdominal wall. This is posterior. If you're standing here, you're inside the abdomen. This is the person, you're standing here. In front of him, it is there. Okay, so this is the posterior view. I hope you understood what I'm trying to tell you. So now the boundaries of the Hasselbalch triangle. Superior laterally, we have the inferior epigastric artery. Superior laterally, so this is the lateral side and this is the medial side. Okay, so superior laterally we have the inferior epigastric artery. Inferior laterally we have the inguinal ligament, and medially we have the rectus abdominis. Superior laterally we have the this inferior epigastric artery, and superior medially we have the inguinal ligament, and here medially you have rectus abdominis. Okay, so now types. Now we are looking into types of direct hernia. We have the lateral direct hernia. As I told you, this entire thing is a Hasselbalch's triangle. It is divided into two parts with the help of median umbilical ligament. This is your lateral part. This is the lateral part and this is the medial part. So therefore we have two types of direct hernia now. First one is the lateral direct hernia. It comes what happens, it is from the lateral part of the Hasselbalch's triangle. Contents of it will be skin, external spermatic fascia, cremasteric fascia, fascia transversalis is present, as it is directly pushing the posterior wall of the inguinal canal, and then you have the extraperitoneal connective tissue. So the contents are important, you need to remember it. See, skin we have, next we have the external spermatic fascia, cremasteric fascia, then you have the fascia transversalis over here. Okay, this is important to remember. As it is directly pushing the posterior wall of the inguinal canal, and then you have the extraperitoneal connective tissue. Next is the medial direct hernia. This is from the medial part of the Hasselbalch's triangle. This was the triangle, here this part, medial part of the Hasselbalch's triangle. Contents in this will be skin, external spermatic fascia, you have the conjoint tendon. So this is important to remember, conjoint tendon. That is transverse abdominis plus internal oblique muscle form conjoint tendon on the medial side. Yes, we read it on the starting. See, this is in the medial part, right? On the medial side we already know what happens. They form the conjoint tendon is present. So instead of these things, what do we have? We have directly the conjoint tendon. So this is important to remember. And then we have the fascia transversalis, then you have your extraperitoneal connective tissue. So instead of your instead of your cremasteric fascia, what do you have? You have your conjoint tendon. That you have to remember. Not like instead of it, you just know that medial, if it is the medial part of the direct hernia, medially we all know conjoint tendon is present. Do you want me to take you to that diagram? Okay, wait, I will. Yeah, see, conjoint tendon is present medially. We have written it down also. In the posterior wall, conjoint tendon is present in the medial 2/3 and internal oblique muscle is present in the lateral 1/3. So medially we have the conjoint tendon. So therefore in the medial direct hernia, you will write conjoint tendon is present. Okay. So then we have fascia transversalis and extraperitoneal connective tissue. So by this we complete the inguinal canal. I will revise once again what we have, a quick revision I will give you guys so that you remember what we have learnt in this video. First, we learnt what inguinal canal is. It is an oblique. It is like this. It is oblique. It is 4 centimeter in length, extending from deep to superficial inguinal ring. Extent we covered. How is it directed? It is directed forwards, medially. It is directed downwards, forwards, and medially. Okay. Moving on, we learnt about superficial inguinal ring, that it is triangular. It has two cruras, lateral, medial, pubic crest. And where is it present? It is present in your external oblique in the external oblique muscle. Okay, and where will you locate it? I will locate it 1 centimeter above and lateral to pubic tubercle. If a patient is present and they ask you show me where is superficial inguinal ring, you will locate it 1 centimeter above and lateral to pubic tubercle. Next is deep inguinal ring. Deep inguinal ring, it is oval in shape. Where it is present? It is present in fascia transversalis. External oblique muscle will be there, internal oblique muscle will be there, then you have transverse abdominis, then you have the fascia transversalis. So here you have the deep inguinal ring, here you have the superficial inguinal ring. Okay, so and where will you locate it in a patient? You will locate it is ½ inch above the mid inguinal point. We learnt about the difference between mid inguinal point, midpoint of inguinal ligament. Moving on to the boundaries, we all know anteriorly it is external skin, superficial fascia. Then you have the external oblique aponeurosis in the whole extent. Internal oblique muscle present only in the lateral 1/3. Posteriorly, what do we have? Posteriorly, we have the whole of fascia transversalis, medial 2/3 of conjoint tendon, and the medial most part we have reflected part of inguinal ligament. Roof is formed by the arcing fibers of transverse abdominis and your internal oblique muscle, and the floor is formed by your inguinal ligament and lacunar ligament. See, roof is formed by arched fibers of internal oblique and transverse abdominis. Floor is formed by inguinal ligament and your lacunar ligament. So to understand lacunar ligament, we went into the modifications of inguinal ligament. You can just remember this diagram. This is the reflected part of inguinal ligament. This is inguinal ligament this is the pectineal ligament between these two, the triangular fossa. It is nothing but your lacunar ligament. Then we learned the differences between aponeurosis, tendon, fascia, ligament. Moving on to the contents. You're like, content is so easy. No, it's just ilioinguinal nerve. Then you have spermatic cord, and in case of females you have round ligament of uterus. But writing so much is not enough. You need to write the contents of spermatic cord as well, because contents of spermatic cord are nothing but content of inguinal ligament. We also learnt about a note about the ilioinguinal nerve, how it enters in between and it exits through your superficial inguinal ring. Moving on to the spermatic cord, this diagram is very important. In this diagram, we have covered the coverings of the spermatic cord: external spermatic fascia, cremasteric fascia, internal spermatic fascia. The contents is very easy. First one is vas deferens. We have 3 arteries. First one is the artery to vas deferens, artery to cremasteric muscle, testicular artery, veins, mammaliform plexus, lymphatics, nerves. We have genital branch of genitofemoral nerve. Then you have the remains of processes vaginalis. Contents are over. We learned about the mechanisms. We have 4 mechanisms. First one is the flap valve mechanism, which refers to the oblique nature of inguinal canal, because of which during intra-abdominal pressure these two are approximated to each other. Next, we learnt about the shutter mechanism. This is personally my favorite mechanism. It's very easy to remember also. Internal oblique muscle is present and in the anterior wall and the roof as well as in the posterior wall. So when it contracts, it acts like the shutter of a shop and it shuts down and it is approximated to the floor. Then we have the slit valve mechanism. Slit valve mechanism refers to the superficial inguinal ring, the contraction of your external oblique muscle, because of which the 2 crura are approximated. These 2 crura are approximated, because of which herniation does not take place. And the last one is your ball valve mechanism. You can remember testes, and because of which when there is contraction of cremasteric muscle, the testis is pulled upwards. And the cremasteric fascia coagulates around the superficial inguinal ring and plugs it. And then we learnt about the applied anatomy, inguinal hernias, indirect and direct, the Hasselbalch's triangle, and 2 parts in the Hasselbalch's triangle, that is medial and lateral. Congenital and acquired. Congenital is due to patent process vaginalis, and acquired is due to increased abdominal pressure, which can be due to weightlifting, chronic cough. Direct inguinal hernia, it occurs medial. It occurs medial to the inferior epigastric artery, and directly the posterior wall is pushed. Okay, by directly pushing the posterior wall of the inguinal canal forward. This is your Hasselback's triangle. The boundaries of Hasselback's triangle types. You have lateral and medial, and the contents are important. In contents in the lateral, we have skin, external spermatic fascia, cremasteric. Then you have this fascia transversalis, extraperitoneal connective tissue. Here, you have to remember we have the conjoint tendon. Skin, external spermatic fascia, conjoint tendon, fascia transversalis, and extraperitoneal connective tissue. So thank you for watching this video. I hope the entire concept of inguinal canal is crystal clear for you guys. Thank you.